Welcome, everybody, to another edition of Wildcard Wednesday. It is March 25th, 2026, and I am Stacy Buck, President and Senior Consultant of RadRx. So before I get started, I wanted to let everybody know that I still have several cases to go through that were sent to me, and some of them are quite lengthy and quite complex. And so this week I was busier than expected, and so I only had time to go through and set up one of the cases. My goal is to try to do two every week, but depending upon how complex the cases are that you send to me and how busy I am is going to determine whether I get to do one or two per week. Some weeks I might even do three if I have more time and if they're not really lengthy cases. So if you've sent in a case and you haven't seen it yet, it's still on deck. It will be coming up in a future episode. So I just wanted to give you an update on that. So with that said, let's take a look at the case that we have for this week. So the individual who sent this case in also sent me the prior CT scan that was done. I did not include that here in the video because we actually have the findings from the CT scan here in the clinical information for the interventional radiology report. So there was a CT scan done on December 9th, which identified the pulmonary arteriovenous malformation. And now the patient is presenting for embolization of that pulmonary AVM. When we look at the clinical information, we see the measurements for the AVM, and then we see the statement that says that he presents today for pulmonary angiogram and right middle lobe pulmonary AVM embolization. So based on this clinical history, we see that the diagnosis was established from a prior CT scan, and I don't see any mention as to why an angiogram is needed. It doesn't even say, angiogram with possible intervention. So there isn't enough here in this paragraph for me to determine that the angiography is going to be truly diagnostic in nature. So I'm not actually going to recommend coding the angiography in that case for that reason. Also, you'll see when we get into the details of the report, as far as the angiography findings are concerned, there's nothing in the report that's going to indicate that the findings were diagnostic. In past episodes, I've mentioned that sometimes you may not see the documentation in the history, the clinical history that's provided, but in the body of the report, the physician may say, based on the above mentioned findings, decision was made to intervene, and then they move forward with the procedure. So we don't have any type of language like that in the report. So for now, my recommendation is going to be not to code for diagnostic angiography, and then simply focus on our catheter placements and also the intervention that is being performed. So quickly, I always want to start looking at the procedure list, read that numbered list there. To see where we're going, I want to look at this and I want to compare the documentation in the report to the numbered list. Sometimes there are things in the numbered list that are not documented in the report or vice versa. And we always want to make sure that we have documentation to support our steps. Mostly if something is mentioned on the procedure list, if it's not documented, sufficiently in the body of the report, then we would want to go back and do a query on that and ask for an addendum if necessary. So here we see that the physician's getting venous access. We see angiography occurring of the main pulmonary artery, the right pulmonary artery, and then subselective catheterization for branches of that right middle lobe pulmonary artery. Then we see that an embolization is performed. Physician used moderate sedation, and then modifier 22 is listed. So right there, I can tell you that's not enough for modifier 22, right? Most of you know that. Just saying you want modifier 22 does not make it so. So I'll go over some of the requirements for modifier 22 after we look at the coding of this case. Okay, so with the findings, we see, well, first of all, in the technique, it does mention the moderate sedation being used, but there is no moderate sedation time there. So we don't have the ability to code that without the documented time. When we jump down into the findings, which is actually the details of the procedure, we see that the procedure was started with ultrasound guidance for vascular access. And so we see that it was done under direct ultrasound guidance. We see that it confirmed patency. What we don't see in the documentation is mention of a permanent image being stored. So if you listen to past episodes, you know that I've mentioned that the American College of Radiology says that the documentation, the report does not have to say permanent image stored. but you need to be able to produce a permanent image. So the question is, do you know for a fact that your physicians always store the permanent image? If so, then you could go ahead and code this 76937. But a best practice would be to have the physicians document in the report that a permanent image is stored, so there is no question for assigning the 76937. So once the catheter goes into that right common femoral vein, we see wires being placed, and then the catheter ultimately is going to end up in the main pulmonary artery here. And when the catheter goes into the main pulmonary artery, a pulmonary arteriogram was performed. Now, I have inserted imaging codes within the body of the report for discussion purposes. So I already mentioned I'm not going to code the diagnostic angiography on this particular case, but I am inserting the codes just for your reference for educational purposes. So first here we have that catheter going into the main pulmonary artery, which that gets coded with 36013. But once the catheter comes out of that main pulmonary and then goes into the right pulmonary artery, that 36013 is going to be bundled with the 36014, which we'll see in just a moment. And then the imaging at this point would actually be non-selective imaging if we were going to assign it, and that would be code 75746. But the catheter ends up moving more selectively into that right main pulmonary artery, which is going to change that imaging code when the right pulmonary arteriogram is done from that catheterization of the right main pulmonary artery. So that would end up becoming a 75741 for the unilateral selective catheterization. And then that is going to bundle the 75746. So that would get absorbed into the selective catheterization code. Then from there, the catheter is advanced, and it says that it was used to select multiple subsegmental right middle pulmonary lobe arteries until the branch supplying the right middle lobe AVM was identified. So here's the issue we have. We have the statement multiple, but it does not tell us how many branches, 2, 3, 4, doesn't name the specific branches, so we don't know. And then also, if we follow this statement through with the angiography that's performed there, it just says that, subsegmental, that let me back up. It was used to select multiple subsegmental right middle lobe pulmonary arteries until the branch supplying the right middle lobe AVM was identified. Now, if we think back to our procedure list, the procedure list mentions angiography of branches in step 4, but we have no detail to support that. So I don't see any supporting documentation for the 75774, which I've talked about in past sessions, how you have to have the catheter advanced more selectively, and then you have to have additional findings. So I wouldn't recommend putting the add-on code in this particular instance, even if we were coding diagnostic angiography. Then the physician goes on to say it was technically challenging and time-consuming due to the acute angle of origin of the target vessel, requiring prolonged fluoroscopy time, resulting in high radiation dose. So we have a statement that is explaining why the modifier 22 is requested. And I'm going to go through the requirements at the end here. I actually put together some bullet points on that. So we'll come back to modifier 22. So if we go on and we look at the case, it says the catheter was then advanced distally into the branch supplying the pulmonary AVM, which was confirmed with contrast injection. So at this point, with the statement being multiple arteries there, then when the statement multiple is used, then I allow 2. That's what I will allow. We know that we have at least 2 if it's multiple. So you'll see that I assigned the 36015 the first time. And then I allowed a second 36015 here. So I'm assigning 36015 for 2 branches at this point, 2 separate branches being catheterized. So I'm not doing anything additional because I don't see any I don't know how many branches. And then we see that this branch ultimately was embolized with the microvascular plugs. And then we see following embolization, delayed filling of the AVM was noted. The branch was then embolized further back with microcoils. So we're still looking at the same branch being embolized. And then the post-embolization angiography is going to be bundled. So the embolization, that's all occurring in the same operative field. We're not going to code more than one embolization for that. Then after that, it says the microsystem was used to select a small branch proximal to the coil pack. Angiography. Angiography was performed, which did not demonstrate filling of the pulmonary AVM. So my question is here, was this a separate branch from the two that were already catheterized? Because we're missing detail here, I'm not exactly sure if I should give another 36015 for that or not. So possibly we have another 36015. But again, with the lack of the detail on the individual branches, I may hesitate to assign the third one there. And then just to jump back to the embolization code there, it's an arteriovenous malformation. So that is going to be coded with a 37242 for that particular clinical indication. So as far as our coding is concerned, if we're taking a conservative approach on this case based completely solely on documentation, so I would not code the 76937 without knowing that a permanent image was stored. And then as far as the catheterization codes are concerned, I feel comfortable doing 36015 2 times. I wouldn't necessarily recommend putting on the third one, even in that last paragraph that mentions that branch, because I don't know, was that possibly a branch that had been selected prior and now it's being selected again? I can't make that determination from the documentation. So it could be a branch that was already selected potentially. So I would hesitate to add the third 36015. And then the diagnostic angiography, as I mentioned, I wouldn't report any of that based on documentation. So really here, what comes down to final coding, what we know for sure, there's 36015 times 2, and then there's 37242 for the actual embolization. So we would want to see some more detail in this report to be able to pick up the other codes. So again, in a situation like this, I would go back to the physician and I would query them and I would ask for an addendum for any details that are missing. So let's talk about modifier 22, since the physician requested this and did actually put a statement in the report. So to use modifier 22, the physician has to give a specific reason that the procedure was more complex than usual. And then they have to clearly describe the extenuating intraoperative circumstances and then do a detailed description of the additional work performed, mention any technical challenges, quantification of increased effort. So even if you're putting like in this statement here, where the physician mentioned it was technically challenging and time consuming due to the acute angle of the origin of the target vessel, requiring prolonged fluoroscopy. Okay, well, what is the typical time to do a procedure like this? And what was the total time to do the procedure like this? That will help quantify that for modifier 22. So we have a reason, but we don't really have a lot of detail, for that reason. So I'd want to see a little bit more in the report. So when the physician is requesting to use modifier 22, they should give the specific reason why the procedure was more complex. Note any technical challenges. We see a technical challenge in this case. Quantification of increased effort, time comparison, we don't see that here. Description of increased intensity, any physical or mental effort required. Severity of patient condition, that may be a factor in the particular case. And then technical difficulty, why the case required more skill, resources, or effort. And then you always want to have your supporting clinical details, any other pre-existing conditions, additional diagnoses that the patient may have. If there's something unexpected that's encountered during the case that's going to require the prolonged procedure, more difficult procedure, any complicating factors. And then as far as, valid justifications, we want to see increased time with comparison, increased intensity or effort, significant technical difficulty, or severe patient condition impacting procedure. So this one statement alone, it does have like some of the elements, but when I look at this, I want to look at this from the payer perspective. So I may look at this with my physician and I may understand that, okay, I understand what you're saying. I believe, maybe I personally believe the case needs modifier 22, but if a payer is looking at this, is this statement going to be enough that the physician said it was technically challenging and time consuming due to the acute angle of the origin of the target vessel? That I don't know that the one single statement would be sufficient. The one thing that I would recommend putting in here, in addition to that, at a minimum, would be putting the typical time to do this procedure versus the amount of time that it took to do this procedure. And I have no idea how long the procedure took because we don't even know the sedation time. So I can't even begin to guess on how long that took. So This one actually does have a statement supporting that. A lot of times I see physicians will add modifier 22 or request for it to be added, and they don't have any statement that would support using modifier 22, or the only thing that they will have is that the procedure took longer than expected. So let's say a case typically takes 90 minutes, just throwing that out there as like general, and then a case took 2 hours. Well, the fact that a case took an extra 30 minutes when most of your cases of similar take 90 minutes doesn't necessarily in and of itself justify modifier 22. We have to go back to this list of the criteria and explain why. So, okay, that procedure took an extra 30 minutes. Why did it take an extra 30 minutes? It isn't sufficient to just say that it took an extra 30 minutes or even an extra hour. Obviously, when we're getting into an additional hour of our procedure time, there should be an explanation as to why it took an additional hour. So that's just some additional information on modifier 22. If your physicians are wanting to use that, make sure they actually have the documentation to support it in the operative report so they can get the additional payment. There's a lot more out there on modifier 22. Just, I would say, do a Google search on that. Different payers also have slightly different criteria. So you want to make sure that you're meeting the criteria for your payers, and then also requesting an appropriate amount of additional reimbursement as well for these procedures when you are sending in that letter and when you are sending in documentation. So that is our case for this week. And next week, hopefully I'll be back with 2 more cases for you. Until then, have a great week, and I will see you next Wednesday.